Greetings from Tehran, from the 32nd International Congress on Pediatrics. To all audiences and participants, welcome to the Nephrology Panel. And on the third day of the International Congress, I hope you all have passing good days, good daytime, maybe morning, maybe evening from all around the world. I wish you have a very, very good time with health and happiness during this difficult COVID pandemic day. I'm so happy to have the honor of being the manager and the presenter of the nephrology session together with the distinguished awesome lecturers, my dear professors. I'm sure we are going to have a very, very good time together, knowledgeful and fun. I should remind you that for next day's program, you can visit the website, visit the application, and also the posters of each panel for leading you to each panel's time, day, and also the Zoom meeting IDs and passwords. For Iranian audiences, I should mention that if you want to get the CME credits, you should register on cme.ir, and then in order to qualify for the panel, you should pass the quiz up to 48 hours after the panel. So you will get the points. Finally, we are going to be with dear professors. I give you a little introduction. First of all, Professor Ayşe Akcan-Arikan from Baylor College of Medicine, Houston, Texas, USA, with acute kidney injury and pediatric heart failure. Then Professor Akash Deep from King's College London Hospital from London, UK, with acute kidney injury in children with chronic liver disease. Then we have Professor Kazem Rahimi from University of Oxford, London, UK, with hypertension burden in children. And also Professor Andrea Székely from Semmelweis University, Budapest, Hungary, with identification of postoperative acute kidney injury in pediatric cardiac patients. Okay, I want to take your time more. We are going to be with my dearest professor, Ayşe Akcan-Arikan. Welcome, dear professor. Just as a special greeting, çok hoş geldiniz. Davetimizi kabul ettiğiniz için çok teşekkür ederiz.
Teşekkür ederim. Thank you so much for having me. Good evening, everyone. It's good morning here in Houston, Texas. We're hoping for a good day with everything else that's going on in the country today. It's a pleasure to be here. I'm going to share the screen if that's okay.
Of course. You are the co-host now and you can share your screen. We are with you.
Thank you so much. Today, I am invited to talk to you about something that actually is quite near and dear to my heart, acute kidney injury in pediatric heart failure, and explore different aspects of it. Here is my disclosures. I don't have anything pertinent to this presentation. The only disclosure I have is that I am on clinical service, and even though I've silenced everything, I can't silence the pager. So if it goes off, apologies. So today, we're going to review acute kidney injury, what it means in terms of the patients with heart failure in the pediatric population, and delve into worsening renal function and cardiorenal syndrome and how these might be different or related to each other, and talk about subtypes. We're going to visit the epidemiology and talk about at-risk patients, but we're going to focus largely on acute decompensated heart failure in medically managed patients. The other patient populations that are vulnerable, mechanical circulatory support, and the cardiac surgery associated, we're not going to really focus on, and there is a talk coming on later in the session about the cardiac surgery associated AKI. Review briefly the pathophysiology, especially as it has implications on treatment and treatment resistance, which is diuretics, and then think through the continuum of worsening renal function to CKD. So who is at risk? There is different flavors of heart failure, right? So the congenital heart surgery, surgical patients are at risk, but we're going to focus on acute decompensated heart failure today. And and start by saying that definition is not really very clear. Most of the time in the literature, it is decided by the investigators who has heart failure and who doesn't. There is a big quality consortium in North America trying to standardize cardiac ICU management and outcomes. The cardiac ICU version is called PC4, and they defined acute decompensated heart failure, which we're going to call heart failure from now on, as documented systolic and or diastolic ventricular dysfunction, and at least one of the following: vasoactives and or diuretics, which are ubiquitous in these patients, as you will know, respiratory support of any type of positive pressure ventilation, including high flow nasal cannula, or mechanical circulatory support. Heart transplant patients are also another very vulnerable patient group for kidney injury, but we're not going to focus on them too much today. Actually, not much. We're just going to mention one brief aspect. So let's just start with the basics. What are the available renal function measures for us in the ICU? The easiest, cheapest, most readily available, very much ignored, but really quite valuable functional outcome, measure for kidney function is urine. Then we have filtration markers, creatinine and cystatin C, in certain healthcare settings where it's available, which is also another serum protease that gets filtered from the glomerulus. Then we have damage markers, also so-called novel biomarkers, although they're not by any means new anymore. They've been around for over a decade, but we're not really focusing on non-clinical and largely experimental use of those biomarkers today. In order for any agent, any protein, any mediator to be used as a functional marker or a marker of renal function, it either has to be filtered across the glomerular basement membrane and secreted, or it needs to be constitutively expressed or induced in the tubules, either by the resident cells or by the cells that are infiltrating the tubules with injury, which are usually the immune cells with their molecular phenotypes. So the novel biomarkers are going to come from these infiltrating cells. The filtration markers are going to come across the GBM, and the urine itself is going to be our easiest available biomarker, and we're going to focus on that largely today. I'm going to put it to you that we don't know how to define acute kidney injury in the pediatric heart failure population. When you look at the literature, incidence varies from 15 to 50%, but it depends on the definition used. But if you look at renal replacement therapy, that incidence is in the single digits. And oliguria even though very important, is not rigorously tested as an AKI marker and has a different facet in the heart failure population. And some increases in serum creatinine, like we're going to visit in a minute, might be transient and actually not necessarily associated with kidney injury. Here are the standardized pediatric acute kidney injury definitions, and I am sorry to say that these are not very consistently and rigorously always applied to the vulnerable heart failure population, either in research settings or in the clinical arena. So the reverse chronological order, KD, GO, P, Aiken, and P, Rifle, define kidney injury by relative changes in creatinine from baseline, relative fold increases, or varying durations of oliguria. This oliguria or relative oliguria is something that we're going to come back and visit very frequently throughout the next 20 minutes. If we use different definitions, we might actually be describing different things in different populations. So an elephant could become a spear or a wall or a rope. So this is something that I always like in order to put us in the right mind frame going forward, trying to understand this problem. What is the evidence out there? Here is the most recent, almost hot off the press from PC4 Quality Consortium of all of the heart failure, acute decompensated heart failure admissions admitted in 23 centers that contribute to this registry. In these admissions, they looked at outcomes in general, interestingly, contrary to what used to happen about 5 years and definitely 10 years ago, congenital heart disease related heart failure is now becoming more important and prevalent as the etiology for heart failure. These investigators did not use a standardized AKI definition like we mentioned. They only looked at renal replacement therapy that was available to them. 3% of encounters had renal replacement therapy. Mortality was almost 5-fold higher in those patients compared to the rest of the cohort. Definitely a vulnerable, high-risk population. But when we use a standardized AKI criteria, this is our patient population that we looked at, patients who are hospitalized with acute decompensated heart failure anywhere in the hospital. Using Aiken and P-rifle at admission actually yielded different frequencies of AKI. Aiken was revealed that patients actually had about 1/3 of the patients had AKI at admission and more than 50% by P-rifle. We tried to use this to apply it to the concept of cardiorenal syndrome, this organ crosstalk that happens in heart failure. This second slide I'm showing you is that it's emphasizing that at discharge, some patients had not actually recovered their renal function, still had persistent renal dysfunction, and they actually were more likely to get readmitted. So what is cardiorenal syndrome then? Sometimes these concepts are used interchangeably, and in the literature, you will actually find more information around under cardiorenal syndrome in heart failure than you would find under AKI. It's really renaming of an age-old concept. There is 2 broad types, acute and chronic. The type 5 is the systemic disease-related version, which is not really our topic today. Cardiac failure leading to renal injury could be acute and chronic, and it's named type 1 or type 2. That's what we're focusing on. So acute cardiorenal syndrome type 1 would be triggered by a cardiac event, and through a variety of mechanisms would lead to acute kidney injury from either hemodynamic changes or oxidative stress or neuroendocrine perturbations that happen. Chronic cardiorenal syndrome, on the other hand, would be a chronic heart failure setting where there is similar but slightly different mechanisms at play, which leads to acute kidney injury that doesn't recover, or repetitive events of acute kidney injury, which then heal in a maladaptive fashion, leading to apoptosis, fibrosis, and then eventual progression to chronic kidney disease. And the initial abnormality, the heart failure that actually triggers an adaptive response in the body by increased systemic and renal arterial vascular resistance, which is then through neurohumoral and non-osmotic vasopressin stimulation leads to renal sodium and water retention with restoration of circulatory integrity, over time becomes maladaptive, and that actually can perpetuate kidney injury. And even though we've conceptualizing it in a very simplified fashion, the main topics that we can actually focus on here is neurohumoral activation, which is initially compensation for increased afterload, decreased preload, and decreased cardiac output, which then over time leads to venous congestion and fluid overload, and may be exacerbated by some of the side effects of medications used for heart failure, leads to kidney injury, which becomes a vicious cycle. The mechanistic relationship between these concepts is not as simple as I've shown you in that schema. It's actually much more complicated, making it more complex to approach these patients. So worsening renal function in children, what is this? This was first described from our center by Dr. Price, who's done a lot of work in cardiorenal syndrome in children. And he was the first to propose worsening renal function as evidence for pediatric cardiorenal syndrome in patients with acute decompensated heart failure. The patients who did not have worsening renal function, which he described as an increase in creatinine of 0.3 milligrams during the hospitalization, were virtually free from mortality or VAD support, ventricular assist device support, compared to the patients who developed it. And the 0.3 milligrams came from this ROC curve, where it actually had the best sensitivity and specificity for predicting bad outcomes. It is the same construct that is used in adult medicine, so it nicely parallels the stage 1 acute kidney injury and the worsening renal function that's being used in adult patients with heart failure. Now, there is a very important thing. This might be the most important thing you can take away from this talk today, and it's this link between congestion and AKI and the worsening congestion leading to worsening AKI. Here on the left-hand side, I'm showing you percentage of patients who have worsening renal function, and the panels are CVP, cardiac index, systolic blood pressure, and wedge pressure. From left to right, the indices that are indicated in red are increasing. So what you would immediately see is that the only stepwise increase that almost is a dose response is with higher CVP, even with low cardiac index, which we would normally think about when we think about heart failure. Worsening renal function is not as frequent as with high CVP. And here is the ROC curve. This cardiac index is actually almost the line of unity, whereas the CVP has a better ability in terms of predicting worsening renal function. And here it is very nicely illustrated again. This is high cardiac index, high CVP. This is low cardiac index, high CVP, and this is glomerular filtration rate. And you can see that the high CVP group, regardless of the cardiac index, has lower GFR. We actually looked at it in our own patient population. This is a work by Dr. Price and me, Dr. Jack Price, and we looked at a congested patient population, the ones with Fontan palliation, and measured their Fontan pressures via cath. And those patients who had higher Fontan pressures, which of course is higher filling pressures, higher venous pressures, were more likely to actually have lower GFR, controlled for their age differences, suggesting that worse congestion also plays a role in the pediatric population. This, of course, is very biologically plausible because perfusion pressure is the difference between the mean arterial pressure and CVP. And as CVP is rising or intra-abdominal pressure is rising because patients are congested, have tense ascites, the perfusion pressure of the kidney is going to decrease. This is a slide that actually is about cardiac surgery-associated AKI-related fluid overload, but I like to use it in order to illustrate that there is immediate peri-illness findings that are linked to adverse outcomes from congestion and fluid overload, and there is long-term outcomes associated with it. Congestion in general is related to impaired wound hearing, decreased lung compliance, could lead to ventilation, and worsens heart failure. And then over time, we talked about CKD, but there is also bigger global impact about functional disability and death in this patient population. So this is our patient population again, pediatric patients admitted with acute decompensated heart failure. We followed 75 of them, and 25 of these patients, so 1/3 failed medical therapy, so either required a VAD or went on for transplantation. And we defined standard cardiorenal syndrome using standardized AKI criteria, and fewer patients would fulfill CRS syndrome if Aiken was used at admission due to nuances in definition, how baseline is defined, and P-rifle was able to pick up more. But here's what I want you to pay attention to. Even the patients who had no CRS by either criteria on admission were actually likely to develop it during their hospitalization, and the peak CRS predicted failure of medical therapy. So clearly it's something that needs very meticulous attention. And diuretic use is ubiquitous in this population, and loop diuretics are commonly the first-line agents. They do have some adverse inadvertent consequences that actually worsen arterial underfilling and maybe stimulate renin, angiotensin, aldosterone system, so work against us. But what is, and other diuretic regimens could be added to loop diuretics in order to troubleshoot this diuretic resistance that could develop. But what is more important for us is the ability to actually assess the kidney's response to diuretics. So it's not diuretic resistance, it's diuretic responsiveness. Here's an example from cardiac surgery where Lasix and urine output response to Lasix furosemide in 2 hours and 6 hours immediately after one dose actually could differentiate patients who would develop AKI in the coming days from patients who would not develop AKI. This also is something we inherently know in clinical practice. We know patients who don't respond to diuretics probably have worse injury, but I don't think we quantify it enough. And that's what I would like to show you today about some of our data that we actually recently did and published, and not think of it as a diuretic resistance, but more like a diuretic response phenomenon. This is in adults conceptualized as weight loss per unit 40 milligram dose of furosemide or equivalent, or net fluid loss per milligram of loop diuretic, because that is what we're trying to get to. We're trying to decongest these patients. And trying to reach negative sodium and water balance. And we need to remember the diseased heart operates over a very narrow spectrum of safety. While it's not good to be congested, it's also not good to be over-diuresed, because that might also be problematic. So we looked at 108 patients less than 21 years of age with heart failure in our system who were receiving loop diuretics for over 72 hours. And we looked at their diuretic response and quantified it or categorized it as high diuretic response versus low diuretic response. The patients who were younger had less obvious congestion on physical exam, like pleural effusion or edema, and interestingly, higher GFR were more likely to have low diuretic response, and they actually had worse outcomes, longer length of ventilation, or more requirement for CRT and a worsening renal function. In fact, for each unit decrease in diuretic response, mortality or mechanical circulatory support need increased by 3%. But what astonished us is that at 72 hours, 34% of these patients who were trying to be diuresed for heart failure had more IV fluids in than out. In fact, if you look at it, regardless of diuretic response, 37% in one group, 54% in the other group had IV fluids. This fluid exposure is a frequently ignored part of care in clinical practice. I'm showing you a series of cardiac surgery-associated AKI papers, not to look at the data itself, but just to look at actual urine output being not very oliguric per the standard definition, and the fluid exposure not really being recorded or kept track of. In fact, in one patient population where prophylactic peritoneal dialysis catheters were being placed post-cardiac surgery to improve volume replacement or volume management, the patients with PD catheters did better in terms of reaching negative fluid at 48 hours. But if you look at it, the patients who didn't have the PD catheters actually ended up getting more fluid. This is not always modifiable, right? Because the patients who are very sick have to have an obligate intake. Sometimes they're getting resuscitated. Sometimes they're on multiple meds, like you see here with multiple pumps. So how much of this is a surrogate indicator of the underlying severity of illness is difficult to tease out, especially with retrospective data. And the concept of diuretic resistance versus cardiorenal syndrome is sometimes difficult to differentiate when you only look at the laboratory data, because they can actually look quite similar with high BUN and high creatinine. This is another very intriguing, incredibly elegant study that I would like to draw your attention to. And this is from adults, but I think it actually has implications for us. So here is decline in EGFR. Here is decline in dilution markers, meaning improvement in decongestion. So BMP decreasing, hematocrit increasing. They have differential impact on GFR. Decline in EGFR actually is associated with increased risk for death, whereas better decongestion is associated with decreased risk for death. But when these things are combined, they actually have opposite effects depending on what is being achieved. So the patients with decrease in their BMP and increase in their hematocrit, meaning they're congesting from not responding to responding, actually lose the signal as they're getting more decongested. What does this mean? The creatinine that increases when patients are decongested is not necessarily associated with bad outcomes. So even though there is a GFR increase that seems to happen from the creatinine levels going up, that loses its signal for adverse outcomes. So successful decongestion with the creatinine increase that accompanies it might not necessarily be the same thing as cardiorenal syndrome and failure of medical therapy. Another concept that we will briefly visit is this improvement in decongestion, improving renal function. This is a group of patients from the Pediatrics registry who had VAD implanted, and I'm going to blow that up here, right here for you to show you that upon implementation, which also improves decongestion and improves filling, the GFR increases quite precipitously across the patient population. Now, it doesn't always stay that way. These patients are at risk for developing CKD later on, as shown by multiple investigators. We looked at our own patients who are on continuous flows and showed that multiple AKI events was the most significant predictor for failing to recover GFR after VAD implantation. So as I'm wrapping up, I'm going to say cardiorenal syndrome cannot be managed away from the bedside. So if you're trying to differentiate whether a patient is becoming diuretic resistant or has inadequate diuretic response, there is many things that go into the play of that patient that needs to be evaluated as a whole, and physical exam needs to be in the middle of it so that we can actually direct the patient's care appropriately, because the differential diagnosis of diuretic resistance or failure of diuretic response could be anything from inability to take meds or refusal to actually using inappropriate medications that interfere with our diuretics, to nephron adaptation, to giving too much fluid, to true kidney injury, or other changes that are happening with worsening heart failure that eventually will lead more support with mechanical circulatory support or heart transplantation if that's the path that the patient needs. So take home points: acute kidney injury, worsening renal function, cardiorenal syndrome are defined slightly differently, but they're all common in pediatric heart failure. If we can use standard definitions, we'll facilitate recognition and talk about the same thing and be able to compare patients across populations. We actually can quantify response to decongestion quite quickly, and successful decongestion is key. So we need to beware of working against ourselves with fluid exposure. Cardiorenal syndrome frequently worsens in the sickest. This is very nicely demonstrated. Failure to respond might mean more support is needed, and long-term follow-up of this, the vulnerable patient population is essential and definitely would contribute to improving outcomes. With that, I thank you for your attention, and I'm going to turn it over to the moderator.
My dear Professor Ayşe, thanks a million for your nice and awesome presentation. Thanks God that I have multiple chance of having your presentation and be more knowledgeable about the nephrology and AKI section in heart failure. And also it is a big chance to see your beautiful face even online here from the camera. Dear Professor Akcan, maybe you saw in the chat section there are two questions. If you are ready and if you let me, I want to ask them over.
Absolutely, absolutely.
Thanks a lot. First of all, do we need to restrict the fluid of every patient with acute heart failure?
I think that's a very good question. It will depend on the physical exam and the patient's physical exam findings for you. What I'm referring to is this knee-jerk response of putting everybody on so-called maintenance IV fluids. So very frequently we'll find our residents, our fellows, even our attendings don't necessarily think about what we're trying to achieve. Every therapy should be goal-directed, right? We don't only think about goal-directed therapy in just resuscitation of sepsis. We have to think about goal-directed therapy in every situation. So if the point is to try to decrease congestion, I think giving extra IV fluids to the patient doesn't really make much sense. However, there is situations that obviously will be different. For example, a known heart failure patient might come with exacerbation of maybe CKD due to an intercurrent illness, because these are pediatric patients. They have, childhood illnesses. So it would be a case-by-case basis, but I would say it has to be a very thoughtful and deliberate action and decision. It should not be a knee-jerk response.
Many thanks for your complete definition. And the next one, how do we manage the electrolyte imbalances in patients with heart failure?
I think that's like a whole session in itself. So
yes, we need another panel for it.
I think it needs 4 different speakers because everybody has a different approach. So typically, in nephrology, what we teach is that water follows where sodium goes, right? So typically we would try to not give patients a lot of sodium supplementation, but there is, most of these patients who are on loop diuretics would require potassium supplementation. It's a great idea to actually anticipate that and start it even before patients develop hypokalemia. The hyponatremia issue is a little bit challenging because there is some adult literature that suggests that if you actually give them high concentration of sodium chloride, you can improve the tubular response to diuretics. We do tend to supplement our patients if they develop hyponatremia. What I will say is my pet peeve is not to diagnose and interpret every metabolic alkalosis as contraction alkalosis. Many of these patients have chloride depletion from their diuretic use. So it is very important to deplete their chloride, especially if they don't actually have good response to diuretics. In fact, low chloride is probably a bigger mediator in diuretic resistance and low diuretic response than we previously identified and understood, and needs to be studied both in adults and pediatrics.
So nice. Dear Professor, as I told you in preliminary session, your lecture is awesome and exciting and interesting. So questions are coming and coming. The next one, one of our doctors asked that you said renal perfusion is related to MAP minus CVP or preload. Is it correct or not?
So renal perfusion of any organ is going to be mean arterial pressure, which is the driving pressure, and the resistance to drainage from the venous end, which is going to be your central venous pressure. Preload is a bit of a different concept, correct? So it really depends on, now let me wear my intensivist hat. It really depends on whether your patient is on positive pressure ventilation, whether your patient is on room air. Yes, preload does play a role in terms of determining your mean arterial pressure in the end, because it will play into your cardiac output, but it doesn't really have any role in this definition of mean arterial pressure minus CVP per se. But the IAP there, which I had abbreviated, was for intra-abdominal pressure, because there is some patients who are congested, like cirrhotics, which you're going to hear about, I think, a little bit, who might have increased intra-abdominal pressure, who actually will have a higher intra-abdominal pressure than CVP. So the perfusion pressure there is going to be the difference between MAP and intra-abdominal pressure, and not the CVP.
So nice. I think it is the advantage of having a lecture with multitasking, with multi-professionality, with awesome lecturing techniques. Thanks a lot. And the last one, someone mentioned that rising creatinine in these patients is not equal to worsening patient situation. Yes or not?
I said that, didn't I? And it's shockingly
Yes.
true in adults. So in adults, if you actually want to decongest someone, meaning they have a lot of fluid overload, and goal-directed diuretic therapy is used, and patients get hemoconcentrated, their BMP decreases, their fluid balance improves, but their creatinine also improves, those patients don't have as high mortality as the patients who get the same therapy and have their creatinine elevate, which means their GFR is lower, but fail to decongest. So we probably are not smart enough or don't have the tools to be able to tease out who is going to respond in what way first. And this concept of worsening renal function not being an indicator of kidney damage, but being related to hemoconcentration and successful decongestion has not been proven in pediatrics. This is an adult concept, but there is a lot that we take and extrapolate from adult literature into pediatrics. It's not, I think it deserves study in our patient population to be able to understand what truly is just changing of total body water and the creatinine increase due to that, and what is related to true tubular injury and worsening renal function, which will have an adverse outcome.
So it's better to keep an anterograde concept to research about on this position, point and topic. And the next one, what else do we have to judge about patients' volume status in these patients chemically? What else do we have to judge chemically about patients' volumes? I said you are one of our best lecturers, so we have to put you in many panels. So
people use a lot of things, right? In clinical practice, we look at the BUN creatinine ratio. We look to see if the hematocrit is changing. It's a little bit difficult if you're drawing a lot of labs on a very little patient and you're inducing iatrogenic anemia to just look at hematocrit, because it is probably different in adult patients. Some people look at BMP. I'm not a big fan. I like weights. I weigh patients twice a day. I think that's a very easy thing to do. It's it should be done in the same consistent fashion on the same scale. But I'm a nephrologist. I love weights. Weight for me is a vital sign. So I can't really see a patient without a weight. So I'd recommend maybe just tracking weights as opposed to getting more labs.
And also it is so applicable. I think good for your patients. Good for your patients.
Thank you very much.
Many thanks.
What time would the Q&A be? If you could roughly give me an idea, because I have to go.
Dear Professor, of course, we have 3 lectures in front that we are going to have the video lectures for them. But I think we finished with your Q&A. You present 3 or 4 panel for us. So
okay, wonderful. If you'll excuse me from the Q&A, I'd be very delighted. Not that I don't want to spend more time with you, but I'm getting so many texts. That's the reason my eye keeps going to my nurses.
Oh, we are so sorry for that. But we are so sorry for taking your time. We are so honorful and so thankful for having you. It was a big chance and big honor for us. And we hope and wish to have you again in panels, in webinars, and also in person in Iran.
That's wonderful. Pleasure is mine. Thank you. It's
Thanks
been
a lot.
a big pleasure to participate in your wonderful organization. Best of luck for the rest of it. I'm following it and it seems to be a great success. So congratulations.
Thanks a lot. Have a good day, dear professor. Take care. Okay, thanks a lot, dear audiences and dear participants. We are going to be with the lecture of Professor Akash Deep from King's College Hospital, London, UK, with AKI in children with chronic liver disease. We are going to have video lecture, then we are going to be with you with questions. If you have any question, you can use the chat section below and we are going to share it with the lecturer.
Thank you for this kind introduction. My name is Akash Deep. I am the Director of Pediatric Intensive Care at King's College Hospital in London. I chair the Critical Care Nephrology section of the European Society of Pediatric and Neonatal Intensive Care, and I'm also the co-chair for the Science and Education Committee of the Pediatric Intensive Care Society of the UK. An absolute privilege and honor to be speaking at this forum. And what I have been asked to do is to talk on acute kidney injury in children with chronic liver disease. Now, what I'm going to do in the next 30 minutes is to take you through the various manifestations of kidney disease which can take place in children with chronic liver disease. And specifically, I'll be talking about hepatorenal syndrome. But what I'll do is start off with what happened in the AWARE study in the liver database, concept of inflammation of acute and chronic liver failure, and as I said, take you through the journey of hepatorenal syndrome and end with the recent advances in acute kidney injury in liver disease. Now, if you look at this cartoon, you can see that there are three different kinds of explants. You've got on the top a liver, which is architecturally normal, which has got an enzymatic defect. Okay, you've got, on the other hand, a liver here, which has completely lost its architecture. It's a collapsed liver. This is a liver of a chronic liver disease. It's cirrhotic, and there is no option but to transplant this liver. And here, you've got a liver which has got regenerating nodules, which are these green ones, and collapsed architecture here. And it is this balance between these collapsed architecture, the necrotic architecture, and the regenerating nodules, which will decide whether this liver is going to regenerate on its own or will end up having a transplantation. And the reason I'm mentioning it here is because each of these three livers have a potential to get acute kidney injury. These three livers plus post-transplantation are the 4 or 5 different scenarios in which a patient with liver disease can get acute kidney injury. So it was the very famous study, the AWARE study, which was published by us in 2017. We looked at the epidemiology of acute kidney injury in critically ill children. And when we had a deep dive into patients with liver disease, you can see here that we had patients with GI or liver disease about 1,100, patients who were likely to have liver disease, though more information was required, were about 300, but highly probable were about 90. So we did 2 kinds of analysis. We looked at the 91 children who most probably had liver disease, and we also included those 91 with the likely probability of 284 children. So we analyzed about 375 children who had liver disease in the AWARE data set. And if you look here, I mean, whether it is stage 1 or stage 2, this light blue bar is the liver database, and the dark blue is the other patients with diseases other than the liver disorder. You can see that stage 1, stage 2, stage 3, or any stage AKI is much more in patients with liver disease. So basically, about 60% of patients with liver disease can have AKI at any given point in time. And if you look at the rest of the AWARE cohort, about 26%. So patients with liver disease are at 3-fold more risk of getting acute kidney injury. And if you look at mortality, you will see that it's 5.5% in patients with liver disease versus 3.4% in patients who did not have liver disease. This is unpublished data, but this is a data from the AWARE data set. Now, before we go into the nitty-gritties of the kidney disorders in liver patients, a very important concept of acute of acute and chronic liver failure syndrome versus acute decompensation. So here is a patient whose liver disease is gradually progressing. The patient is going downhill. And as the liver disease is progressing, the liver numbers go off, ascites, portal hypertension, bleeding, varices become more severe. And what happens is, as a part of the decompensation of the disease, kidneys get involved as well. So kidney involvement parallels the deterioration of liver disease. This is your decompensated liver disease. On the other hand, you have a patient who's ascetic, who's got portal hypertension, sitting stably in the ward, but something happens here. It's an acute insult, bleeding, you have a loss of volume, massive paracentesis, and you've got a rapid downhill of your liver function. And this patient rapidly becomes a patient with multi-system organ failure. And this is acute on chronic liver failure syndrome. So these two syndromes are distinct. Acute decompensation, where the patient's liver disease has decompensated, whereas acute and chronic liver failure syndrome is where an acute insult has converted a stable patient into a multi-system organ failure. Now, though the mortality here is high in ACLF, but there's a chance that this patient can actually go back to where we started, whereas in the other cohort, the liver failure will take the kidney disease down as well. And therefore, there is no chance that this liver disease will recover and the patient will end up getting a transplantation. Now, this is something which is very novel and which people are talking about all the time, is a concept of systemic inflammation. So it all starts with the bacterial products across the portal hypertension bowel into the gut. You get lots and lots of cytokines. There is a complete imbalance between your pro and anti-inflammatory cytokines. And what you get is inflammation. You get inflammatory mediators affecting different organs. And if you look at it, what gets affected the most is the kidney. So kidney affection as a part of the ACLF is a part of inflammation. So if you have acute decompensation, you will get a chronic systemic inflammation state because of translocation. And when you get ACLF, there's a further acute increase in systemic inflammation because of any insult, be it bleeding, be it infection, be it anything else. And the patient ends up into a multi-system failure. And that is what this syndrome is all about. If you look at it, ACLF1 is only renal involvement, ACLF2 is renal plus 1 extra renal, ACLF3 is renal plus 2 extra renal organ involvement. So more severe the organ failure, more higher the grade of ACLF. And if you look at this, kidney is in the center of classification of this liver disorder. So more severe the kidney disease, higher the failure of the liver, and higher is it on the MELD scoring. And this is how the online system looks like. You can see that whether it's serum creatinine, renal replacement therapy, or the use of vasopressors here with hepatorenal syndrome, this dictates the severity of liver disease. This dictates how severe the patient is going to be and how urgently the patient should be placed for liver transplantation. And then we in pediatrics converted that into a P-CLIF SOFA score. CLIF is your chronic liver failure consortia. And if you look at it, everything is converted into pediatric based on centiles. And whether it is to do with your respiratory status, to do with serum creatinine, you can see it's about the upper limit of normal, whether it's less than 2, more than 3. And based on this, we classify the patients into different categories of acute and chronic. And this is a paper we have just published. It's got published last week, actually. And you can see that higher the grade of rifle criteria with ACLF, more is the mortality. So kidneys are central part to classification of ACLF. But the question is, we always used to say, whenever kidneys get involved in patients with liver disease, it's going to be hepatorenal. And the question comes, is every acute kidney injury in liver disease hepatorenal syndrome? The answer is actually a big no, because if you look at the recent classification, you will find that patients who have got acute and chronic or acute decompensation, they can have non-HRS AKI, where you have got hypovolemia due to gastrointestinal bleeding, you can have GI fluid losses, you can have excessive use of diuretics, or it can be nephrotoxic drugs, You can have bile acid nephropathy, but very importantly, don't forget your intra-abdominal hypertension, because the ascites gets tense, it presses on the renal vessels, the patient doesn't pass urine, and we classify them as acute kidney injury. So this is non-hepatorenal syndrome acute kidney injury, whereas then the other kind of injury is the HRS-AKI, which is your hepatorenal syndrome acute kidney injury. If you look at the epidemiology, 50% of patients with cirrhosis and ascites will develop AKI. Hepatorenal syndrome will constitute, if you look at different papers, a very, very small part of this population. Only 7.6% of all 129 cirrhotics with AKI had HRS as the cause of deterioration. And if you look at another multicenter trial, out of the 423 patients with cirrhosis and AKI, about 1/3 patients had ATN, 1/3 had pre-renal failure, whereas about 20% had HRS1 and 7% had HRS2. So though hepatorenal syndrome is very important because the treatment is specific, its contribution to the deterioration in kidney function is actually quite limited. And the commonest precipitant of unprecipitated AKI is degree of ascites. Now, is there a difference between adults and pediatrics? Now, if you look at adults, there are numbers are more, the etiologies are different, and they have a longer waiting time, which means that the patient keeps on deteriorating, waiting for a transplant, and kidney gets involved more often, and hepatorenal syndrome gets more often. But in children, biliary atresia is the most common cause. You get the Kasai doesn't work. We actually observe them. If there's no resolution of bilirubin within 3 months of doing a Kasai, we say that the probability of this patient getting a liver transplantation or dying within 2 years is of the order of 90%. So we list them and we keep a very close eye on them, and we give them a transplantation very early. Therefore, these children do not deteriorate as much as the adults do, and the incidence of hepatorenal syndrome is even lower than in adults. Now let's just go back to acute kidney injury in general critically ill patients, and it's based on two things. One is your serum creatinine, whether it is your absolute value or a percentage increase from the baseline, and urine output. But both these parameters, whether it's the creatinine or the urine output, have got a problem in liver cirrhosis. Serum creatinine will depend upon your liver synthetic function, and it will depend upon your muscle mass. Now, liver synthetic function is gone, therefore the production of creatinine is low, and because of the decreased muscle mass, your baseline serum creatinine is low. You start at a lower level, and to reach the definition of AKI, your GFR really, really falls before you pick up serum creatinine being high and diagnosing AKI. Therefore, serum creatinine seems to be a very late marker of rise in patients with AKI, in patients with chronic liver disease. And therefore, this association called International Club of Ascites proposed this, that we should take out the urine output, because the urine output could be falsely raised in these patients because of use of diuretics, or they could have an avid retention of sodium despite the GFR being normal. Therefore, the urine output is out. And they said, let's talk about baseline serum creatinine within the last 3 months if the baseline serum creatinine is not available in the last 7 days. And there is a percentage rise. You can see here an increase in serum creatinine more than 0.3 milligram per deciliter within 48 hours, or a percentage increase more than 50% from baseline, which is presumed or assumed to have taken place in the last 7 days. They have staged it, stage 1, 2, and 3. There are criteria for progression and regression. And then we also talk about when do we call it no response, when do we call it partial response, and when do we call it full response. So this is from the International Club of Ascites. So what exactly is a hepatorenal syndrome? Where does it fit in the spectrum of acute kidney injury? We have said it's rare. We have said that there's non-HRS AKI, which contributes a lot, where it's hypovolemia, acute tubular necrosis, acute tubular injury. But what exactly is hepatorenal syndrome? It's a renal failure in a patient with advanced liver disease in the absence of identifiable cause of renal failure. It means it's a diagnosis of exclusion, and all investigations should be done to rule out other causes, which I mentioned as non-HRS AKI, before we label the AKI as hepatorenal syndrome. Now, this is the International Club of Ascites, which first met in 1996, and they proposed criteria for hepatorenal syndrome. Then, as our understanding became better, they met again in 2007. But the bottom line was, they said, you need to have cirrhosis with ascites, you need to have serum creatinine more than 1.5 milligram per deciliter, and you need to show that after you have withdrawn diuretics and given albumin for 2 consecutive days, there has been no improvement in serum creatinine, no shock, no use of nephrotoxic agents, etc. But if you look at the thing which are circled with red, this criteria requires your serum creatinine to reach 1.5 before you diagnose hepatorenal syndrome. 1.5, as I said, you start off with a very low baseline serum creatinine. It means you really, really have to wait to reach 1.5 before you can diagnose hepatorenal and before you can start your treatment. And it's very well known in literature that later you start the treatment, less efficacious it's going to be. If you allow the serum creatinine to rise and then start treatment, the less efficacious it is going to be. Therefore, again, these criteria were revised in 2013, and they say we have to diagnose HRS as a form of AKI. So we are not talking about 1.5 anymore. We are talking about diagnosis of AKI according to the criteria I just mentioned, more than 0.3 or more than 50%, and remaining criteria remain the same, i.e. cirrhosis and ascites, no shock, no response after 2 consecutive days of diuretic withdrawal. But the main thing is we are not waiting here for the patient's creatinine to go beyond 1.5. And the previous criteria of type 1 HRS and type 2 HRS, where type 1 HRS was acute deterioration and creatinine going beyond 2.5, whereas type 2 used to be a gradual rise in serum creatinine to a level between 1.5 to 2.5 milligrams per deciliter. That is no longer used as well. So we are talking about here an acute rise in serum creatinine and satisfying the other criteria and not going with any level of serum creatinine. So these are the basic differences with HRS AKI and non-HRS AKI. As I said, it's to do with systemic hemodynamics. It is to do with extrarenal organ failures and very, very importantly, systemic inflammatory response. You get more inflammation, as I'm going to talk later, in acute tubular necrosis in a non-HRS AKI than in HRS AKI. This is the data unpublished from King's, where we looked at all our patients with biliary atresia who were listed for transplantation, which means that all of them had a deterioration of liver function to an extent that they required liver transplantation. 76% had gradual deterioration, they were our controls, and 54% of them had acute deterioration, went to multi-system failure, and we call them as acute and chronic liver failure syndrome. And you can see that in the patient with ACLF, both the mortality pre-transplantation and post-transplantation is high because they already had kidney dysfunction pre-transplantation. And if you look at the multivariate analysis, you can see here that the presence of hepatorenal syndrome and the use of renal replacement therapy were independent risk factors for mortality in a patient with ACLF in children. So renal decompensation has a poor prognosis in children with biliary atresia and acute and chronic liver failure syndrome. And then this study. This was a study from All India Institute of Medical Sciences in Delhi, where they looked at their large cohort of acute and chronic liver failure syndrome. They had chronic liver failure patients, about 600, excluded all the compensated and decompensated liver disease, and took only ACLF, which included Wilson's disease, autoimmune hepatitis, and they found that of the 84 patients, 22.6% of them had AKI, about 47% at admission, and the remaining developed during the course of their hospital stay. They had used the KDIGO definition for AKI, and their poor outcome was defined as death or need for transplantation within 3 months of occurrence of AKI. And the median duration from when ACLF occurred to the development of acute kidney injury was about 4 weeks. 1/3 of the patients had hepatorenal, 1/3 had sepsis, 20% had nephrotoxic drugs, and the remaining had other causes in the form of dehydration and bile pigment-related acute tubular necrosis. And if you look at the univariate analysis, high bilirubin, high INR, high PELD scores, high systemic inflammatory response syndrome, and the occurrence of bacterial peritonitis were associated with the occurrence of AKI. But when these were entered into a multivariate analysis, they found that there were two factors: high bilirubin, more than 17 milligrams per deciliter, and the occurrence of a systemic inflammatory response, which independently predicted the occurrence of AKI. And you can see here, when it's no AKI, the survival is better. When there is AKI, the survival is poor, and the hazard ratio for death is 7.7. So a patient who's got ACLF, if you control for all covariates, it has got a hazard ratio about 7 times more for patients to die as compared with patients with no AKI. And these patients with AKI, as you can see, about 50% of them had died, and only 26.3% survived with a native liver. So AKI in the presence of ACLF is bad. And how does hepatorenal syndrome take place? It takes us back to a chronic liver disease patient with portal hypertension, where you have got lots of inflammation going on in the gut. There is translocation of bacteria and bacterial products there, production of endotoxins, and these endotoxemia produces pro-inflammatory cytokines, which then causes vasodilatory substances, especially your tumor necrosis factor alpha and interleukin 6, and this causes dilatation in the splanchnic arterial bed. Once it gets dilated, you get decrease in your systemic vascular resistance, decreased effective blood volume, and your renin-angiotensin system gets activated, your sympathetic nervous system gets activated, and basically what you get is renal vasoconstriction and the occurrence of hepatorenal syndrome when you use nephrotoxic drugs, when there is sepsis, when there's excessive use of diuretics, and here is where hepatorenal syndrome takes place. So in summary, it's about splanchnic vasodilatation, which triggers your renal angiotensin aldosterone system, which triggers your sympathetic nervous system. There is a release of vasopressin, and it all causes renal vasoconstriction, and hence the occurrence of hepatorenal syndrome. Now the question is, acute kidney injury is AKI. Why are we worried about what kind of AKI it is? If you look at this cohort, you can see that if you have hepatorenal syndrome, your survival is really poor, 15%, as compared to when it's infection or hypovolemia or parenchymal nephropathy. And you will see that the odds ratio of dying when you have got hepatorenal syndrome is about 7 times more. So you need to know, need to be able to differentiate that the acute kidney injury which you are dealing with is hepatorenal syndrome or non-HRS AKI, because it has got both prognostic and therapeutic considerations. You've got various biochemical clinical criteria, but it's very, very difficult. I can assure you that a patient who is having ATN or hepatorenal syndrome, I would say it will require really a sit-down process with the MDT team to say, what are we dealing with at this moment? Is it HRS or is it acute tubular necrosis? And as I said, various things were done, fractional excretion of sodiums, rule of cystatin C, but what has recently come up is a rule of urinary biomarkers, whether it's NGAL, whether it's kidney injury molecule 1, interleukin 16, or the liver fatty acid binding protein. And in this study, you can see that if you have got acute tubular necrosis, you have got higher levels of NGAL. And if you've got even different kinds of hepatorenal syndrome, you can see it differentiates very easily from the acute tubular necrosis because it's ischemia, and ischemia leads to more shedding of NGAL in the urine. Therefore, you can differentiate acute tubular necrosis from hepatorenal syndrome by the use of biomarkers. Now, we looked at this paper where there were about 65 cirrhotic patients. Renal biopsy was done, and they had unexplained renal dysfunction where the serum creatinine was more than 1.5. There was no hematuria, no proteinuria, and the ultrasound was normal. But they still found that though it was functional renal failure, 28% of them had structural changes on their renal biopsy, including tubular interstitial injury, glomerular injury, and vascular injury. So the conclusion of this study was that the patients who may appear to have functional renal impairment may have underlying parenchymal lesions. And this is the toll-like receptors, which is a marker of inflammation and renal dysfunction. You can see that when it is acute tubular necrosis, more toll-like receptor 4 expressions and more calprotectin, which is another marker of inflammation as compared to when it is HRS. So therefore, there is more inflammation in the tubules when there is ischemic, when there's acute tubular necrosis as compared to hepatorenal syndrome. And this potentially could be a new biomarker and a potential for new therapy. Now, we as intensivists get involved, I think, quite late. What we do is we wait for the GFR to decrease, we wait for the kidney failure to take place, and then we take action. Whereas we are taught about early goal-directed therapy, we need to start treatment early. We need to modify the nephrotoxic drugs. We need to make sure that we mitigate the inflammatory injury. We need to make sure that the patient is well filled and the volume status is well calculated. And we need to act early. We should not be acting when the damage has started to take place. So therefore, if you look at the paper which I discussed earlier, where bilirubin was high and there was systemic inflammatory response, this group, as soon as they would get a patient with ACLF, with these high-risk factors, they would start the early targeted interventions in the form of stopping or modifying the nephrotoxic drugs, stopping diuretics, early use of kidney-friendly antibiotics for sepsis. They would start replacing the volume if there's a volume loss. And if they felt that the patient was having HRS, they would start early initiation of terlipressin and albumin, which I'm going to come later, and early initiation of renal replacement therapy. So it is very important to keep a very close eye that this patient is at a high risk of developing acute kidney injury. So let's prevent it. And if we cannot prevent it, and if we have to treat it, initiate treatment early. So how do we treat it? We need to do the basics correctly first. Make sure the precipitating factors are treated, whether it's GI bleeding or hypovolemia, whether it's infection, whether it's a large volume ascites. So make sure these factors are addressed first. And once these factors are addressed, then you talk about medical treatment. And if it is hepatorenal syndrome, as I said, the main problem is splanchnic vasodilatation. So you need to use a vasoconstrictor which specifically acts on the splanchnic vasculature. And that is something like vasopressin or terlipressin or ornipressin. And if you combine it with albumin, what happens is it then increases your circulating blood volume. And then by increasing the circulating blood volume, everything else dampens down. You get a decrease in renal vasoconstriction and the reversal of hepatorenal syndrome. So vasoconstrictors. So various vasoconstrictors, whether it is, as I said, ornipressin or terlipressin, you can use octreotide, and there's a role of albumin as an antioxidant and as a volume expander. Now, what does terlipressin do? It's a V1 receptor analog. It's a long-acting synthetic vasopressin analog whose half-life is about 6 hours, and it can be released over a sustained period of time and therefore can be given as a bolus or as an infusion. And this is where I said it acts on the V1 receptor and causes splanchnic vasoconstriction. But we need to be careful because it causes vasoconstriction. It can cause vasoconstriction in other beds as well. You can get your blueness of your toes and fingers. You can get coronary ischemias or GI ischemias and lead to intolerance of feeds. So you need to keep a very close eye on the side effects of terlipressin. And this was an unfortunate patient at King's, which we have ACLF, which we were listing for transplantation, had got medically resistant HRS, was on renal replacement therapy, but he developed intramural area. As you can see, the lactate was climbing up. So this patient had to be delisted because this patient developed side effects because of terlipressin. In pediatrics, literature is really, really poor. Whatever I could find, these two studies, they have used either as a bolus of 20 microgram per kilo or an infusion of 10 to 20 microgram per kilo per hour. And the management dilemmas continue. And the first question is, with albumin or without albumin? Which vasoconstrictor? Because the evidence is equivocal. Should I use a bolus? Should I use an infusion? And if the patient responds, what is the definition of response? And if the patient does not respond, when am I going to stop the vasoconstrictor? And if I treat inflammation or the cytokine storm, will it help? So this is one of the two studies by Arun Sanyal's group from Virginia and Richmond, where they had randomized the patients 1-in-1 to receive either terlipressin plus albumin or placebo plus albumin, and then they kept on doubling the dose if there was no response. And you can see here in the patients who had responded, the serum creatinine is nicely coming down as compared to patients who did not respond, where the serum creatinine is going up. And you can see that the HRS reversal, though there is no difference at 6 months, but there is some response here in the first 2 weeks. It means the patients who respond will respond quite early in the treatment, and the best predictor was a low baseline serum creatinine. No patient who had got a serum creatinine more than 5.6 milligram per deciliter responded to treatment with terlipressin. The message is start treatment early and don't serum creatinine to go beyond 5s and 6s. And this is the same group which published this data in 2016. And they said that we don't want a complete HRS reversal. Even if it's a change from baseline in serum creatinine, that will convert it into survival as long as there is a more than 50% decrease in serum creatinine from the baseline. And if you look at this data, 60% of patients who had a significant decrease in baseline had actually not achieved the complete HRS reversal, which the previous study had. So aim for a decrease in serum creatinine rather than complete HRS reversal. And we saw here that the 90-day overall survival was more than 50%. You can see here it's more than 50%. And approximately 30% of patients received transplantation, and the transplantation-free survival with responders and non-responders was 30% in both treatment arms. So this gave us a message that you need to start treatment early and not aim for treatment, a complete HRS reversal. You just aim for a decrease in serum creatinine, which is more than 50% of the baseline. The question is, will all patients with HRS respond to terlipressin and albumin? And a meta-analysis showed only 50% respond. And this is important because terlipressin has got the side effects of a V1 vasoconstrictor and has got severe side effects. So we want to restrict it to that group which we think will respond. The question is, can we predict which group is going to respond to terlipressin and albumin and which group is not? Because very important to know when to stop, as important it is to know when to start. So we say serum creatinine either less than 3 milligram per deciliter, between 3 and 5. Very poor response if it goes beyond that. If there is no response by day 4, we say probably there is not going to be response any further. You start the treatment early and stop it if there is no response by day 4. And you need to aim for a sustained increase in the mean arterial pressure rather than only the initial rise. And this is a very elegant piece of work by Salvatore and group, where they actually looked at ACLF grade 1, grade 2, grade 3, and you can see in each of these, if you have a low baseline serum creatinine, your response is much better. So lower the serum creatinine despite the grade of ACLF, your response is going to be better at low baseline serum creatinine. However, you also see that if the grade of ACLF is higher with more multi-system organ failure, you will get a lesser response. And that is predicted here. You can see here that these are the responders, these are the non-responders. The responders survive much better, the mortality is much better in the responders as compared to the non-responders, and the mortality keeps on going up as the grade of ACLF goes up. So more the multi-system organ failure, higher is the mortality. So is it that the response is not taking place because the patient is too sick, or is it that the extrahepatic organ failures are actually acting as the perpetrators, as a vicious cycle of cytokine storm, more inflammation, more system organ failure, and that is leading to non-response of these patients. And this, if you look at this, the same study, you can see that between ACLF 1 and 2, these are the responders, the mortality, this is the ACLF 1 and 2, these are the non-responders. There is a difference, but when you look at ACLF 3, responders and non-responders is hardly any difference. And the mortality in ACLF3 is very high. So this leads to a question, should we even contemplate using terlipressin in patients with ACLF3? But if you look at their mortality, which is 28 days here, these are the responders. It's about 40%, but if you look at the mortality here, which is a non-responder, it's about 80%. So there is a difference in mortality, though not at 90 days, but at 28 days in ACLF3. So what we say is, if you have got good prognostic factors, the bilirubin is not high, the systemic inflammation is not there, you can start terlipressin, and you can stop if you feel there is no response, there is no mean arterial pressure going up, or the serum creatinine is not coming down. So I often get asked this question: should you give a bolus? Should you give as an infusion? This was a study published in 2016 where there were about 50 patients. You can see this is the infusion group, this is the bolus group, and they started with 2 milligram per day as an infusion versus 0.5 milligrams every 4 hours as boluses to begin with, and they kept on increasing till they reached 12 milligrams. And you can see that the maximum daily dose of terlipressin as well as the mean daily dose of terlipressin is much lower in the infusion group as compared to the bolus group. And the very important thing is the number of side effects. 20% developed side effects in the infusion group, whereas 43% developed in the bolus groups. So therefore, the conclusion was that the terlipressin, when it's given by infusion, is better tolerated than intravenous, and it seems to be more effective as well, because the survival, transplant-free survival at 90 days was better with the infusion group. This is our paper, which literally got published about a month back. This is the first paper looking at terlipressin use in critically ill children with liver disease. And we have shown, you can see here, this is the HRS-AKI where the creatinine is nicely coming down, where the non-HRS-AKI, the creatinine is not coming down or going up. And you can see that the lactate is not making a difference here, which means that we are not causing microvascular ischemia, which is leading to high lactate. And therefore, the side effects are lesser. So comparison with noradrenaline, because that's the most commonly used vasopressor. Previously, people have compared terlipressin boluses with noradrenaline infusion and have found equal efficacy, whereas this study is the first study which has compared noradrenaline infusion with terlipressin infusion. And you can see whether it's day 4 or day 7, the response is much better of HRS response on day 4 and day 7 by using terlipressin, 26.7% versus 11% and 41% versus 20% at day 7. And if you look at the univariate and multivariate analysis, whether it is to do with survival or it is to do with HRS response, the use of terlipressin favors both HRS reversal as well as survival. But everything comes with a cost. If you look at the cost of terlipressin and vasopressin as compared to noradrenaline, it's much costlier than a vial of noradrenaline. And therefore, I think a lot of people would prefer using noradrenaline as we guys do. I'll tell you what the protocol is. So this is how we rationalize it. You have got hepatorenal syndrome. If there's ACLF, you start with terlipressin. If terlipressin is not available, as in a lot of centers, you admit the patient to ICU and start noradrenaline. So in United States, for example, terlipressin is not available, so they sometimes use vasopressin as an infusion as in place of terlipressin. If these things don't work, what are the other treatments? You could do a transjugular intrahepatic portosystemic shunt, because that will increase the effective renal blood flow. You can start renal replacement therapy, but that's a very controversial topic. I'm going to speak on this topic in the World Congress in December, where we're going to talk about should we consider renal replacement therapy, because it's a commitment. What are the endpoints? Are you aiming for transplantation? Are you aiming for transplant-free survival? So again, very controversial when to start and when to end. And if you are planning a transplant and the patient has required renal replacement therapy for more than 6 weeks, it is said that the patient will end up getting a liver kidney transplantation rather than only a liver transplantation. This is what we do at King's. We start off with noradrenaline because that's our staff is much more used to it, and we use it very often in other patients as well. When we reach 1, we add a terlipressin infusion, closely monitor the ischemic side effects. We double the terlipressin if there is no response in 48 hours, and stop terlipressin if there is no response completely by day 4, and we consider alternative treatments. Liver transplantation, of course, remains the best and the most definitive treatment. The 1 and 5 year survival rates are not that bad, 77% and 69%. But if you have a pre-transplant renal dysfunction that will determine post-transplant renal dysfunction as well. And patients might get chronic kidney disease and be dependent on chronic dialysis. And as I said, if you give renal replacement therapy for more than 6 weeks, this patient will probably become a candidate for liver kidney transplantation. So this is just to summarize everything I've said, how you diagnose acute kidney injury in a patient with liver disease and how you manage it by removing the precipitants first and then thinking about the medical therapy in the form of vasoconstrictors and albumin. And if things don't work and patients getting fluid overloaded, acidotic and hyperkalemic, starting renal replacement therapy. So the question is, what is there for us in the future? Are there new therapies, and what can be done to improve the prognosis of these sick children before these therapies become available? Right? The crux is differentiate hepatorenal syndrome from acute tubular necrosis. Because if you wrongly give terlipressin to a patient with acute tubular necrosis who is actually who is not hepatorenal syndrome, you will end up causing more harm. So we need to have biomarkers, whether it's in the form of interleukin-6, whether it's the form of NGAL, which can differentiate hepatorenal syndrome from acute tubular necrosis. We've got, for example, serelexin recombinant form of human peptide, which will cause selective vasodilatation in the renal vasculature, increasing blood flow but not causing hypertension. And if this drug is shown to work in human beings, that will be a great achievement in patients with hepatorenal syndrome. And very, very importantly is reduce your inflammation and organ failure, because AKI or HRS-AKI or ATN, they take place as a part of the multi-system organ failure. So plasmapheresis can remove your inflammatory and vasoactive mediators and decrease the surge response and mortality. Mesenchymal stem cell transplantation and granulocyte colony stimulating factors will also help, but they are all experimental and yet not tried in humans. So in conclusion, we need to know what is acute decompensation, what is ACLF, because they're two distinct entities and the acute kidney injuries behave very differently in them. ACLF associated with multi-system organ failure. The criteria to diagnose AKI in a liver versus a non-liver failure patients is different. Every AKI in cirrhosis is not hepatorenal. There's a role of biomarkers to differentiate, and hopefully we will start a study in the European group looking to how to differentiate between different kinds of AKI in chronic kidney disease. We need to prevent precipitating factors, and vasoconstrictors seem to have a role. But we have a couple of unanswered questions. Is at what point can we deny a patient a liver transplantation in this group? Or can we use vasoconstrictors like terlipressin as a prolonged therapy to work as a bridge for transplantation? These are the unanswered questions. Very quickly, as I said, I'm the chair for the critical care nephrology of ASPNIC. If any of you want to get involved in the activities of critical care nephrology group of ASPNIC, please do drop us a line and we will get you associated. We have a very active member group and we will get you associated with that. And this is a huge resource which Stuart Goldstein and myself had put together in a book called The Critical Care Nephrology and Renal Replacement Therapy in Children. So all about AKI, all about CRRT and CRRT in different diseases is discussed in this book. I once again thank you all for inviting me and asking me to talk on a topic which is very close to my heart. Thank you.
Thanks a lot to dear Professor Akash Deep for a nice presentation. Fortunately, we have Professor Deep with us together online. Professor Deep, did you have my voice?
Yes, I can hear you. Hi.
Hi. Good early morning to you.
It is reverse. I'm on night shift, so I'm on call. I'm just taking the handover. Yeah.
Thanks a lot. Thanks for your nice presentation, and thanks for joining us online, even with your difficult situation and hard-working condition. I hope you're doing well and can rest a bit. I just want to say something special. I hope it to be true. Panel mi आपका स्वागत है और हमारी निमंत्रण को स्वीकार करने के लिए धन्यवाद.
Oh my God, you've taken me back. Thank you so much. Thank you.
Yeah, you're welcome. Thanks to you for accepting the invitation again.
No. Thank you very much.
You're welcome.
will the questions be at the end or?
I planned to ask you the questions because we have a question. If you let me and if you agree with me, I'm
Yeah,
gonna.
sure.
Okay, thanks a lot. Is there any role for NGAL or cysteine C for AKI diagnosis in your experience?
So at the moment, what we are
Sorry,
using
just
is...
at the second part. Do you check these biomarkers to identify AKI before creatinine increase?
So as I said, at the moment, we are wholly and solely dependent on creatinine. We don't use it currently, but there is a grant application gone to the European Society where we will start using these biomarkers, especially NGAL. So we are in touch with Biopoto, and the plan is to use Biopoto alongside creatinine first to make sure that we are able to pick up things before creatinine rise and institute the medical therapy, because at the moment we are, as I said, dependent on two criteria which we feel are not very efficient for kidney disease. So, but to answer your question, we are not yet, but we will start using it soon in the future.
Thanks a lot for your nice and complete definition, and also again for a wonderful lecture. I have the chance of enjoying your presentation for multiple times, and it is so nice to have you and see you even online, but face to face. I wish and hope to have you beside us in person and have the chance of hosting you in Iran one day.
Oh, wow. That's a pleasure. That's an honor. Thank you.
And my dear professor, Dr. Agai wants to share some greetings with you.
Yeah, sure.
Because he's so excited with your lecture, with you and everything related to you. I'm passing to Dr. Agai.
Dear Dr. Akash, it is so nice of you to accompany us during this Congress. We are so fascinated by your special personality, your knowledge, and all of them together. We can learn from you and other colleagues, of course, which are helping us in this Congress. So thanks again from me and also from the other colleagues that are involved with the executive committee of the 32nd Congress on Pediatrics in Tehran. Thanks again.
Thank you so much. And as I said, when we were recording this talk as well, Iran has a special place in my heart. And so thank you very much for inviting me, and thank you for making me a part of this Congress.
And you also have a special part in our hearts.
Thank you.
Thank you very much.
Okay, thank you. So can I just ask, will there be more questions towards the end of the session, or am I allowed to nip off?
I think, yes, we won't taking much of your time. Just thanks, many thanks are coming up in the chat section. As you can see, we enjoy a lot. And the biggest gain, and another question is upcoming. May you see in chat section? Yeah. If you let me, I ask.
Yeah, sure.
What do you discontinue? Diuretic for diagnosis HRS in cirrhotic patient? It is very difficult.
So you're talking of a cirrhotic patient here who is developing AKI. So he's got cirrhosis, he's got ascites, and now the serum creatinine has gone up. So in this patient, we give a trial of 48 hours off diuretics and give albumin. And despite that, if the creatinine is not being able to come down, that's when we say that you are actually have satisfy the definition of HRS. It's a trial of 48 hours. We don't discontinue it completely. We give a trial. If after discontinuing diuretics, your creatinine is coming down, so probably it's not HRS. If it is holding on the same state, it is probably HRS. So it's a trial of 48 hours of diuretics.
Oh, thanks a lot for your complete answer. I don't see any question, and we won't take your time anymore. I wish you have a very nice days in front. With
Thank you very much.
Happiness with this COVID pandemic.
Thank you so very much. And as I said, I appreciate your hospitality.
Take care.
Bye-bye. Bye.
Okay, thanks a lot, dear participants and dear audiences. We had a very nice lecture about AKI in chronic liver disease, and we are going to be with Professor Kazem Rahimi from University of Oxford, London, UK, with hypertension burden in children. We are going to have the video lecture. Then with the question part, we are going to be with you. Please ask your questions in chat section.
Hello, my name is Kazem Rahimi, and it's a great pleasure to have been invited to this session to present the findings of two of our relatively recent studies, one looking at the burden of hypertension in children, and the other one looking at the effect of blood pressure lowering treatment in adults. To start with the first study, as I'm sure you're all aware, childhood hypertension is known to be associated with hypertension in adulthood, and that subsequently with adverse cardiovascular events. Measurement of childhood hypertension has been more complicated than those in adults, in part because of the unstable readings that one obtains. Typically, use of percentiles based on age, sex, and height have been recommended to define the normal distribution of blood pressure and that of hypertension. Elevated blood pressure is defined as 90th to 95th percentile, and hypertension anything above 95th percentile on at least 3 separate occasions of reading. In the first study, we were interested to look at the worldwide prevalence of childhood hypertension, and that was a systematic review that identified 47 studies. And this plot summarizes the main findings. On the x-axis is the age of the children from 6 years to 19 years. And on the y-axis, the prevalence of disease. And that is stratified by the 3 different years of 2000, 2010, and 2015. Overall, the prevalence of hypertension was 4% across all years. If one looks at the age distribution, there was a peak at the puberty at around age 15 with a decline afterwards. If one compares the different years, there was roughly a 75% increase in prevalence of hypertension from year 2000 to year 2015. Stratifying some of the analysis as summarized in this figure, some of the key highlights were the heterogeneity of prevalence by weight of the individuals or by the body mass index. As you can see here in the top selection, for instance, the prevalence of hypertension in people who had a normal weight was 1.9. In overweight, it was almost 5%, and in obese, it was in the order of 15%, as you would expect it to be higher. There were also some regional differences in prevalence of hypertension. To just flag the Eastern Mediterranean region, and the prevalence was a bit higher than in some of the other regions, with average prevalence reported in the range of 5.2%. Of course, in children, there is very little evidence about how to manage elevated blood pressure and hypertension. In particular, pharmacological interventions are not well-founded, and most of the intervention centers around lifestyle management and monitoring of the blood pressure over years. On the other hand, in adults, of course, we have had several major clinical trials so far. And a few years ago, we looked at the amount of evidence available. And if one looks at just at the major randomized clinical trials, so far there have been over 500,000 individuals who have participated in those trials of blood pressure lowering treatment. So in a recent study that was presented at the European Society of Cardiology as one of the late breakers, we were interested to look at the effect of blood pressure lowering treatment on cardiovascular outcomes, but stratified by presence or absence of cardiovascular disease, and also stratified by the level of blood pressure that individuals had at baseline that is at the time of going into the clinical trials. So the background to this is, which some of you may be aware of, is we know, of course, a lot about the effect of pharmacological blood pressure lowering on average, which is shown to reduce the risk of cardiovascular disease substantially. But this is in particular for people who have got a high or very high blood pressure. There has been more uncertainty around the effect of blood pressure lowering when blood pressure is below the typical threshold of hypertension diagnosis, which is usually in adults in the order of 140 millimeter mercury, and also whether the effects differ between those who have had a previous cardiovascular disease and those who have not. And the distinction here is we call them typically primary versus secondary prevention settings. So these uncertainties collectively have led to quite different guideline recommendations and, of course, variability in care across the world. For this study, we used a resource provided by the Blood Pressure Lowering Treatments Iris Collaboration, which is a collaboration that I have been leading since 2014. It is a collaboration of some of the largest randomized clinical trials of blood pressure lowering that have ever been conducted. For trials to be eligible for inclusion into the collaboration, they must have at least 1,000 person years of follow in each randomly allocated arm, and they could compare one drug class versus a placebo, different drug classes against each other, or they could compare a more versus less intensive blood pressure lowering regimen. For this particular analysis that I'm going to present the findings for, 48 randomized clinical trials contributed data comprising about 350,000 randomized participants. This makes it the largest type of analysis ever conducted before at the level of individual patient. For this analysis, as I said, we were interested in major cardiovascular events as the outcome, and that is defined as fatal or non-fatal stroke, fatal or non-fatal myocardial infarction or ischemic heart disease, or heart failure leading to death or hospitalization. I won't go too much into the details of the methods, but in a sense, this was a pooled analysis where all the data were harmonized into a single data set, and then we applied a conventional hazards model to look at the treatment effects. And because, as you can imagine, different trials have different intensities of blood pressure lowering, the trials were harmonized for a 5 millimeter mercury systolic blood pressure reduction. To just show some of the characteristics of the individuals included in those studies, stratified in the first column, people who have no prior cardiovascular disease. That is a primary prevention setting. And in the second column, people who had a prior cardiovascular disease. Follow-up duration was on average about 4 years, and there were more women in the primary prevention setting than in the secondary prevention setting. But what is important here is by having such a large data set, we could stratify the patient population into different categories based on the blood pressure at baseline, from a systolic blood pressure of less than 120 millimeter mercury all the way up to equal or greater than 170 millimeter mercury. And as the highlight in this table shows, we had still several thousands of individuals falling into the categories where blood pressure is conventionally considered to be normal or only mildly elevated. And these are obviously adult trials, as one would expect. A substantial number of them would have had previous cardiovascular events or diseases that would render them to be at high risk of cardiovascular disease. And as the lower section of this table shows, many of them were also receiving treatment for prevention of cardiovascular disease. So this is the first figure from the analysis. So one of the key questions that we were asking ourselves is, to what extent is the intensity of blood pressure itself a modifying factor for the relative treatment effects? And this is a meta-regression plot. On the x-axis, you can see the intensity of systolic blood pressure level for each of the clinical trials, with each of the clinical trials being represented with a circle on this plot. And on the y-axis is the hazard ratio for major cardiovascular events, or if you like, the relative risk reduction observed. And as the figure shows, is we just see a graded association between intensity of blood pressure reduction and the relative treatment effects, confirming that the more intensively the blood pressure is reduced, at least at the trial level, and the more intensive, the stronger the treatment effects. Now going to the major outcomes, and these analyses are stratified for a 5 mm mercury systolic blood pressure reduction to enable a better comparison of the trials with each other. So this plot shows the effect in people who had cardiovascular disease at baseline, that is the secondary prevention setting, and it shows that for each 5 mm mercury reduction in systolic blood pressure, the hazard ratio was 0.89. And if one looks at people who had no cardiovascular disease at baseline, the hazard ratio was very similar, 0.91, suggesting that presence or absence of cardiovascular disease does not seem to affect the relative risk reductions observed across those trials. The findings were relatively similar when one looked at the different components of major cardiovascular disease, and that is stroke, ischemic heart disease, heart failure, or cardiovascular disease. Again, there was no evidence of a treatment modification in people who had a previous cardiovascular disease or people who did it. And this is perhaps one of the most striking findings from this study, in this summarized in this slide, where on the top panel we looked at people who had a known previous cardiovascular disease. That is the secondary prevention, and in the lower section of the figure we looked at people who had no prior cardiovascular disease. And in each of those subgroups, the trial population was further stratified into those categories of baseline blood pressure that I described earlier. And what this figure shows is there was no evidence that the baseline blood pressure itself had any modifying effect on the relative risk reductions observed across the trials. In other words, it didn't matter whether someone had a relatively normal blood pressure or a very high blood pressure. And the same amount of blood pressure reduction, in this case, 5 mm mercury, led to a relatively similar proportional risk reductions in the populations investigated. So the summary of this study is that the relative effect of blood pressure lowering is proportional to the intensity of systolic blood pressure reduction. That means the more intensive, the greater the relative risk reduction observed. If one just standardized the studies by a 5 mm reduction in systolic blood pressure, we observed that the risk of major cardiovascular events was reduced by about 10%. There was no evidence that those proportional risk reductions varied by baseline blood pressure values, and down to the lowest blood pressure category of 120 mm mercury in both primary and secondary prevention settings. Now, to conclude, atherosclerosis, as I'm sure you're all aware, is a lifelong process, often starting in childhood. And hypertension, as the systematic review that I presented earlier, is relatively common in children and adolescents, and it tends to be worse in obese and overweight children. When one looks at the age stratification, there seems to be a peak during puberty, but the effects are not sustained after puberty, where there is a decline in the prevalence of hypertension. If one looks at the adult studies, we see that there is no threshold below which pharmacological blood pressure lowering has a different effect on prevention of cardiovascular outcomes. I hope these findings collectively provide a sense that the evidence so far as we are concerned, suggests that whether this is a lifestyle intervention or pharmacological intervention, it seems that at least for prevention of cardiovascular disease, the lower seems to be better. So I'd like to stop there and just to thank the BPL-TTC collaboration and the steering committee, the core analytic group, and the funders including many of the trials that trialists that have supported the activities over the past few years. And I would like to thank you for your attention.
Dear Professor Rahimi, thanks for your nice presentation and informative slides. If you are with us still and you have my voice, regards.
I can hear you.
Regards, dear Professor. Again, welcome to the panel and thanks for accepting our invitation and thanks for a wonderful lecture.
Thanks for having me.
It's our biggest honor, of course. If you let me first, there is a question. If you let me, I go and ask it to you.
Yeah, of course. Go ahead.
Thanks a lot. How can we detect end organ damage in children with chronic hypertension?
I should have put a disclaimer. I'm not a pediatrician, so I'm an adult cardiologist, so I'm not too familiar with it. But I suspect that is not too different from what we know in adults. I suspect, I mean, if you define end organ damage as left ventricular hypertrophy, well, if you define it as renal dysfunction and any other measures, I mean, those, you would have the same tools for detecting those organ damage. But the point that we made in the second study, that in a sense that the management of the blood pressure does not matter or should not matter whether people have gotten end organ damage or not. Of course, they would be having a higher risk of adverse outcomes. But when it comes to prevention, the distinction is not binary.
Thanks a lot. So nice definition. If you have yourself, if you have any comments, any point that you want to share with us, we would be so happy.
I mean, I said, I mean, it's a great pleasure for me to have been invited to this conference, and sad to not be there in person. But given the circumstances, I guess with the Zoom call, it tends to work. And I tuned in a bit earlier and listened to the previous talk. It seems like a great session. Congratulations to you guys for organizing it.
Of course, thanks a lot to you for joining. And of course, with such a distinguished lecturers like you, it should be a wonderful panel. Again, thanks a lot for joining. You are the big honor of the panel and our biggest proud as an Iranian people. Hope and wish to see you one day face to face, not just online. My dear Professor, Dr. Aghai wants to share some greetings with you. I'm passing the voice to the Dr. Aghai now. Dr. Aghai.
Dear Dr. Rahimi, dear Professor, it is a great honor of all of us to have you with us. And thanks. I know you are a very busy man, and I can understand that you have did a great job to accept this invitation and support our Congress. I wish you a very good day, and thanks again on behalf of all our scientific and executive committee here in Tehran.
Thank you very much. I hope that it was of some use to you and to your audience, and
it was
always
great.
A great pleasure.
It was great. Thank you very much, Professor. Thank you.
Thank you.
Again, take care, pleasure. Have a nice day. Goodbye. Khodafez. Thanks a lot to all dear participants and audiences. I am sure you're enjoying the panel and enjoying the informative lectures.